Hello everyone, my name's Jane Roberts, Medical Affairs Dietitian at VitaFlow International Limited, and I'm very happy to welcome you to today's webinar hosted by VitaFlow, titled The Management of Dietary Fibre Intake in Children with Kidney Disease, Clinical Practice Recommendations from the Paediatric Renal Nutrition Task Force. This webinar aims to support healthcare professional education with regards to the dietary management of paediatric kidney disease. Few housekeeping items before we get started. The webinar is intended for healthcare professionals only. The webinar will last about 90 minutes and will include time for questions at the end. If you would like to ask a question, please use the question feature on your screen. All questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar is being recorded and will be available on VitaFlow's website for healthcare professionals in a few weeks' time. PDFs of the presentation slides are available on your screen for download. A certificate of attendance and a self-reflection tool will be sent out by email following the webinar. Please note this webinar has a live German translation option available for those wishing to listen to the webinar in German. Please use the drop-down on the screen to select this option. The question and answer section will not be translated. The views herein are of the presenters and do not necessarily represent VitaFlow's views. The material is accurate as of the date presented and is for educational purposes only and not intended as a substitute for medical advice. The learning outcomes for the session are documented on this slide. We are fortunate to have a host of experts included in today's webinar. Anders Loewe started her career in metabolic diseases in 2001 at the University of Antwerp. In 2008, Anne switched location to Ghent and worked simultaneously as a nurse and as a paediatric dietitian for kidney diseases at the University Hospital of Ghent. In 2011, Anne's career focused on paediatric renal dietetics as well as metabolic diseases in infants, children and adults. Today, Anne specialises in many areas including paediatric renal diseases and paediatric intensive care of the Paediatric Renal Nutrition Task Force. Dr. Evelyn Swart is a paediatric nephrologist at the Department of Paediatric Nephrology, Ghent University Hospital. She obtained a PhD in 2019 on uremic toxin accumulation and removal in chronic kidney disease, a paediatric perspective. She's a Belgian representative of Young Paediatric Nephrologist Network ESPN, a member of the Paediatric Renal Nutrition Task Force and the Paediatric Dialysis Working Group. Her interests include paediatric chronic kidney disease, dialysis and thrombotic microangiopathy. Evelyn has research interests in the pathophysiology of chronic kidney disease, including uremic toxins. Dr. Fabio Paglialonga is a paediatric nephrologist at a Key Children's Centre in Milan, Italy. His main areas of interest are the assessment of dry weight and cardiovascular status of children on chronic hemodialysis, the nutritional status of children with chronic kidney disease, the management of vascular access for hemodialysis in paediatrics, and therapeutic apheresis techniques. Dr. Paglialonga has been a member of the ESPN Council since September 21 and of the ESPN Dialysis Working Group Board since 2019. He also participates in the European Paediatric Dialysis Working Group and is the current chair of the Paediatric Renal Nutrition Task Force. Without further delay, I will hand over to our speakers to start the webinar.
Besides these carbohydrates, also those non-carbohydrate plant cell wall compounds are also included in the definition, like lignin, chitins, and waxes. If you look to the overall, then we know that dietary fiber intake has many health benefits. From the general adult and pediatric population, we know that dietary fiber intake is associated with an improved gastrointestinal health by reducing all-cause and cardiovascular related mortality, by reducing inflammation and also improving the lipids and glucose profile. I will go through some of the major papers in the field. If you see here, this is a paper in adult patients without a specific comorbidity, then you see that people with a high fiber intake, they have a lower risk of total mortality than those who have a low fiber intake. And they see that each 10 gram of dietary fiber daily increase, that this will lower also the risk for mortality with 11%. The same is seen for cardiovascular outcomes, and you see that diets high in fiber are significantly associated with a lower risk of coronary heart disease and cardiovascular disease. In pediatrics, we don't have many studies. We only have a few observational studies, but also those are showing the positive effects of fiber. They show that children with more fiber have a more beneficial lipid profile, have lower rates of obesity, and have also an improved gastrointestinal health. Especially in pediatrics, it's the gastrointestinal health benefits who are mainly established and shown. But now let's go now for the kidney diseases. It looks like that patients with kidney disease even have more benefits of this fiber. And this is a study in adult patients comparing patients with CKD with patients without CKD. And then you see for inflammation parameters like CRP that especially the benefits of fiber are more pronounced in the CKD patients. This is the same for all-cause mortality, where you see that the benefit is especially present for those patients with chronic kidney disease. And there's also quite some good rationale why the fiber intake is relevant for chronic kidney disease. In patients with chronic kidney disease, for instance, we know that when the kidney function deteriorates, that the uremic toxins will accumulate. These are metabolites who are going to accumulate when the filter function of the kidney is decreasing. These uremic toxins, a part of them, are produced by bacteria in our gut.
Diese Toxine werden von Bakterien im Darm produziert. Proteolytische Bakterien produzieren die meisten.
These uremic toxins will also disturb the intestinal barrier, will cause translocation of bacteria, endotoxins, and uremic toxins through the barrier and cause inflammation, oxidative stress, and progression of kidney disease and cardiovascular disease. If you look to fiber, fiber has the possibility to shift a more proteolytic bacteria profile to a more saccharolytic bacteria profile, where you see that more beneficial compounds will be produced. So we have more short chain fatty acids, improved epithelial barrier integrity, all aspects who will really decrease inflammation, improve the overall gut health, and cause more lower inflammation and acid load as well.
Weniger Entzündung verursachen und weniger Säure verursachen.
That the benefits of plant, vegetable fruits are not only related to fiber. Fruit and vegetables, they have many other benefits far beyond fiber intake. We know that the bioavailability of phosphate and potassium is much lower in sources coming from plants. We also know that the content of sodium and the acid load is lower, and they have also a higher content of unsaturated fatty acids. They're also rich in minerals and vitamins and antioxidants. And I think it's really important, you will see it also in the practical translation of the guideline, that we really encourage the natural occurring sources of fiber, because we have this additional positive effects associated as well. And that's also what we see if we ask children or adults to eat more fiber by increasing fruit and vegetables. You will see that the mineral, vitamin intake will go up as well. We have looked also in our Belgian population what the fiber intake is currently in patients with kidney disease. We especially look to the patient with chronic kidney disease, and then you see that a substantial proportion of the children are really failing to meet the recommended intake of dietary fiber. In our cohort, we saw these were patients all without dialysis, so then we saw that 1 in 5 of the patients were only meeting the recommendation. And if you see by decreasing kidney function, so in the lower in the CKD stage 4 and 5, then you see that especially in this group of patients, the fiber intake is in particular very low. But of course, we know that it's very challenging to achieve an adequate fiber intake in this population. We know that these patients have a different appetite, a lower appetite. They sometimes have strict fluid restrictions. They use often exclusively, not often, sometimes in the little ones have exclusively tube feeding. And we often discourage them to eat potassium-rich fruits and vegetables because we really want to avoid hyperkalemia. And how come that, like, what are the factors who are associated to the inadequate dietary fiber intake? So if you look to the last decades, we really have in nutrition and dietary advice, we have really focused on individual nutrients. We have looked to protein, energy, potassium, and phosphate, but we have not paid too much attention to the diversity of a diet, the quality of a diet. And of course, even we see this lower fiber intake also in our general pediatric population. Of course, parental style, ethnic and socio-economic influence are also, of course, playing an important role. And then on top of that, we of course see in kidney diseases that we don't have any practical guidelines to really guide us on how we should prescribe fiber. And we are of course scared of this lethal complication, hyperkalemia. And also in a pediatric population, we really want to ensure that we still keep providing energy dense and sufficient protein intake for our children to really maintain a good growth as well. But of course, I think we know that inadequate fiber intake is also associated with a poor diet quality, a lower intake of vitamins, and so on. So I think it's really important to tackle this topic. And we have also looked in our population to see the relation between fiber and potassium, because of course they are related. As you can see in this graph, you see that they are definitely related to each other. However, we know that the bioavailability of potassium is much lower in fruits and vegetables if you compare them to potassium sources from animal foods. And I think also important to consider is that for instance, in adults, the top 3 most important sources of potassium are not fruit and vegetables. They are beef, chicken, Mexican foods, all animal meat products, animal-based products. And this is also what we saw in our pediatric cohort. Fast foods was also in this top 3. Here we had a contribution also from fruits and milk as well as the top 3 main sources of potassium. We have also looked into the relationship between dietary fiber and dietary potassium, and on the other hand, serum potassium. And we could not find an association between serum potassium levels and the dietary fiber sources. So this is a result that has been also repeatedly confirmed by other studies, especially in adults, where also they couldn't really see an increase in serum potassium levels by increasing these plant-based sources, increasing fiber in the diets as well. So to really tackle this problem and to guide also the practice more, how we should implement in a way that is safe, the fiber, sufficient fiber in our cohort, we started in our pediatric renal nutrition task force with a guideline on this topic. And this is here the team who has all worked very hard in this guideline together. And for that, we used the PICO question focusing on children and adolescents between 1 and 18 with kidney disease. So we included not only chronic kidney disease patients, but also broader. We had as intervention the fiber intake, and then as comparator the age-matched healthy children. And our outcome was bowel function, because this was the outcome that was most studied in pediatrics. And after all the statements were created, we have had a feedback with the Delphi method as well. And in the next slides, my colleague will go through all the aspects of the guideline on how dietary fiber should be incorporated in diets of patients with kidney disease. So I will hand over the word to her, and at the end we will tackle the questions as well.
To start our overview, we had, of course, our guideline thinking process. So we want to see, the main question was to prepare a publication for how are we going to manage the intake of fiber in CKD if we have this big sea of dietary restrictions. So we had to go first, what are the requirements for our children with CKD? Do they differ from healthy children? Then if we know the requirements of our children in CKD, what are the sources of dietary fiber? As Evelyn just said, that there are very big differences between the bioavailability, and that we are kind of in the history of renal diets have focused on the plant-based potassium sources. So we want to see what is the amount of potassium, what are the biggest sources. Then we want, of course, to see how we can assess the amount of dietary fiber. Do we use a diet history? Do we have food frequency questionnaires? Do we have something that is evidence-based for CKD and for children? And then, of course, we can see how are we going to manage the intake with the big C of dietary restrictions. But when we started our research, there was one big thing we had to tackle first. That is, what is the definition of dietary fiber? Because when we did research, we saw that there were a lot of definitions of dietary fiber. We tried to have one definition based on all the national and international definitions of fiber that have been proposed. There were some differences between them, but there was a broad agreement. The questions was how many non-carbohydrate substances were included, how many carbohydrate units are fiber or not. They were using different methods of fiber analysis, and some of the definitions included the demonstrated health benefits for every fiber separately or together, and some definitions did not incorporate the health benefits. Then when we had our definition, I will show it in the next slide, we had to add the terms added fiber and intrinsic fiber, because there was a lot of discussion about how added fiber or synthetically or extracted or modified or whatever, if they have the same health benefits if you add it to a product. And we have, of course, the fact that they miss the protective nutrients and phytochemicals that are present in natural fiber. So we have to find a definition for added fiber and intrinsic fiber. So the intrinsic fiber are the natural fiber in natural food, and added are all the rest. Then in the past, there was a lot of terminology about soluble and non-soluble fiber, but this we didn't use this in our CPR because it needs to be phased out, because it's the solubility of fiber is not really related to its physiological effects. Then we made this diagram where you can see the 4 biggest groups of dietary fiber, how much units of carbohydrates they can have. And then we also added the sources. I will explain it later, but this is an overview of our definition. So in our definition, I'm just going to retake that, we have accepted the largest amount of carbohydrates monomers. We have included the health benefits, and we have also included the non-carbohydrate polymers. Then the main sources of fiber, we took the food questionnaires of different regions. There is a big variation, of course, depending on the region and the eating patterns. But we find that grain products, fruits, vegetables, potatoes, and legumes are the main sources of fiber, of course, the plant-based foods. There was some difference, like Australia, Belgium, UK, USA had grain products as the main source, and France and Spain had more fruits and vegetables. The fiber intake did not differ according to age, but we saw that the fruit intake was the highest in young children when compared to adolescents. And then we also saw that the added fiber, so that's the not the intrinsic fiber, contributes to the total daily fiber intake, even though it does not provide necessarily other beneficial nutrients. And be aware that added fiber can contain other additives, which can be a source of phosphate, potassium, and sodium. For our fiber assessment, I know for a lot of dietitians, which I've seen or have spoken, that fiber is not an item we traditionally evaluate in our kidney diet. So we didn't find a golden standard approach in our research, but yet we find some evidence that you should use a diet history of a typical 24-hour period to determine the baseline and to identify the main dietary sources. If you want to have more detailed information, we propose a 3-day prospective diet. We had some adapted FFQs to improve practical and quick implementation, but there are no studies justifying the use of FFQ in children. But we did have some studies in adults that the FFQ over or underestimates the fiber if you compare it with 3 days prospective diet or typical 24-hour diet history. Then we had a big dive in the fiber requirements of healthy children in the different countries or continents, and we had big lists. And then we made the decision to create an SDI, as we did with the former guidelines. And then we took the minimum and the maximum, and we came across